Rahim. So our next topic after epilepsy is Parkinson disease. So let's talk about Parkinson disease today. So how we're gonna define the Parkinson disease? So it is basically a progressive clinical syndrome that results from the lesion in the basal ganglia, right? So we know that the caudate nucleus, pupillus, and globus pallidus, right, and the thalamus and subthalamus and substantia nigra. So these are the parts of the basal ganglia, right? So the lesions in the basal ganglia can lead to Parkinson disease, right? So basically, it's gonna cause various diseases. So one of them is Parkinson disease. So it is characterized by triad of basically we're gonna see three features like FPR we have TBR, mnemonic care, right? So basically, we're gonna see the tremors, rigidity, and bradykinesia, right? So there will be resting tremors in these patients. Obviously, the intentional tremors are seen with the cerebellar lesions, and we will see the lead pipe rigidity in these patients, and there will be bradykinesia, right? So how are we gonna differentiate Parkinson disease from Alzheimer's disease? So if we talk about neurotransmitters, so um, dopamine will be decreased in Parkinson disease patient and acetylcholine will be increased. While in Alzheimer's disease, acetylcholine is decreased, right? So this is basically dopamine is decreased in due to lesion in substantia nigra, right? So basically dopamine production is occurs in the substantia nigra, while acetylcholine is present in the nucleus basalis of Maynard, right? We will see the Levy bodies, which are actually the clumps of alpha synuclein, right, proteins, and we will see hieronymbodies in Alzheimer's disease patients, which are actually clumps of tau proteins, right? I'm gonna discuss some of the other atypical Parkinson diseases in which we're gonna see the tau protein in that as well, right? So there will be decreased thalamic activity in Parkinson disease, and there will be decreased activity, in globus pallidus internus, right? And there will be akinetic mutism that what we're gonna see in these patients. So let's talk about types of the Parkinson disease. So we're gonna divide into typical and atypical, and then we have primary and secondary, right? So we're gonna divide it into typical, that is also called as primary, and then we have atypical, right? So I'm going to discuss atypical at the last, like we have some of the other Parkinson syndrome like progressive supranuclear palsy, one of the type of atypical disease, and atypical will have poor response to levodopa, right? While typical will be having a good response to levodopa in these patients, right? So let's talk about typical is also called as primary or idiopathic, right? So what happens in the typical type, in primary type, Parkinson disease, we're gonna call it as Parkinson disease. So there will be age-related neurodegeneration, right? It can happen because of the genetics, it can happen because of the sporadic cause. So we'll have the PARK1 gene, right? PARK in gene and PARK gene, that is SCN4A. This is basically an autosomal dominant condition, and PARK in gene that is present on 6, right? Chromosome number 6, which is going to cause the degeneration of the basal ganglia, right? And we have the sporadic cause, right? So peak age is almost 70 years, right? So there will be loss of dopaminergic neurons, so we're going to see the decreased dopamine in these patients, right? And it is replaced by Lewy bodies, just like Hirona bodies what we see in the Alzheimer's disease patients, right? So the next thing is the secondary Parkinsonism, right? So secondary Parkinsonism can be seen with the metabolic cause, can be seen with the Wilson's disease, metabolic like parathyroidism and hypoparathyroidism. Both can lead to calcification of basal ganglia, and this is going to cause the secondary Parkinson disease, right? Then we'll have the drugs, right? And D2 antagonistic drugs like haloperidol, chlorpromazine, and metoclopramide, right? So these drugs can lead to Parkinson disease, and there are some toxins. There are some insecticides like MPTP, that is an insecticide. This can cause Parkinson disease. This can cause neurodegeneration. Then we have carbon monoxide cause, right? This can lead to Parkinson disease, and manganese gas can lead to that. And then repeated head injuries like punch drunk syndrome, like this is seen in the boxers. So boxers will be having repeated punch to the brain. So when there will be repeated punch to the head, so there will be micro infarcts in the micro bleeds in basal ganglia, and this is going to accumulate over time, and this is going to cause the Parkinson disease. So Muhammad Ali is one of the boxers have had this disease, right? So secondary Parkinsonism can also be seen post-viral encephalitis, right? And this can also be seen with, this is called as encephalitic lethargies, right? And we have vascular cause of that. I have talked about one of the syndrome that is called as Benedict syndrome, right? Benedict syndrome, in which we're going to see the ipsilateral third nerve palsy, right, plus contralateral chorea, and there'll be resting tremors and Parkinson like features. So I have talked about the this syndrome in the midbrain stroke series, right? So the tumors can cause that too, right? Hydrocephalus, one of the causes NPH, right? Normal pressure hydrocephalus. We're gonna see the dementia, ataxia, and incontinence. The mnemonic is DAI, right? DAI, and this dementia is reversible, right? So NPH can also lead to that. So there'll be, if we talk about clinical features, so male and females will be having equal involvement, right? So peak age is almost 70 years, and we will see TBR, right, just like FPR. So tremors, rigidity, bradykinesia, these are the features. With that, there will be postural instability. If two of these features are positive, so we can make the diagnosis of that. So tremors at rest and at pronation and supination, and this will be pill rolling tremors, right? So these are more obvious in the thumb and index finger, so this will be just like pill rolling, right? And there will be cogwheel rigidity, or or lead pipe rigidity in these patients, right? So as these patients will be having difficulty to initiate the movements, so this is called as bradykinesia, right? And if we ask them to do some activity or walk, so their gait will be short with increased speed, and there'll be sharp short steps, right? So, and there'll be decreased arm swing. We call overall it as fascinating gait, right? And there'll be short shuffling gait in these patients. And when they are talking, so there will be decreased movement of the vocal cords, so they will be having like whispering movements, right? And this voice is called as monotonous voice, right? And they will be having slow thoughts, and they will be having micrographia, right? So they will be having decreased blink rate, and they might have some other non-motor features like constipation. So at the last, they're gonna get into depression, right? So median survival is almost 15 years, right? So we're gonna see the pseudo dementia in these patients. So let me talk about some of the non-motor symptoms that what we see in these patients. So they will be having anosmia, constipation, and mood and sleep disturbances, right? So these are the features that we get initially in these patients. When they reach up to 65 to 70 years, so we will see the motor symptoms. So we're gonna see the resting tremors, and resting tremors will be of 4 to 6 hertz, right? So we're gonna call it as high frequency tremor when the tremors are more than 8 hertz, right? So the resting tremors are asymmetric, right? These are asymmetric. Usually these are unilateral, and there will be movement between index finger and the thumb, right? So high frequency tremors can be seen with thyrotoxicosis and anxiety neurosis, right? So these patients will be having, they will be walking slowly, right? And when we ask them to initiate the movement, so they will start the movement later, right? So they will be having difficulty to initiate the movement. When they start, they will be having short steps, and right, that is called as shuffling gait, and there will be decreased arm swing, right? When we ask them to stop, so they won't be able to stop because of rigidity component, right? So that's all about the clinical features. So let's move on to the next page and let's see. Right, so um, there is a sign that is called as Myerson sign, right? That will be positive in these patients. If we tap on glabella, so they will be continue to blink, right? So usually when we tap on glabella in the normal patient, so there will be one or twice blinking, and then they won't person won't respond to that. And but in the Parkinson disease patient, if we tap on glabella, there will be continuous blinking of the eye, right? So that is called as Myerson sign. So treatment is, the principle of treatment is start treatment when Parkinson disease is it gets severely it has when severe interference with the routine life, right? So we have the drugs which are available to increase dopamine. We can use the dopaminergic drugs, and to decrease acetylcholine, so we'll have anticholinergic drugs, right? So to increase dopamine, we'll have the drug that is called as levodopa, and along with that we need to give the carbidopa and benserazide, right? And these two drugs are decarboxylase, peripheral B decarboxylase inhibitors. So let me yeah, so if we give the levodopa, so this will be converted into dopamine, right, in the periphery. So we have these enzymes, MOB inhibitors and COMT inhibitors, which we can give in these patients and increase the availability of the dopamine, right, in the brain. So we have this drug that is called as the Entacapone, right? Tolcapone was initially given, but it is withdrawn due to hepatotoxicity, right? So these are basically COMT inhibitors, that is catechol O methyltransferase inhibitors, right? So Entacapone is given. So we have D2 agonistic drugs like bromocriptine, right? So and cabergoline. So both of these can lead to pulmonary fibrosis and cardiac valvular lesions, right? So these are given in the low dose. So bromocriptine can cause Raynaud's phenomena, right? So right. Another drug that we can give is MAO-B inhibitors, right? Monoamine oxidase B inhibitor, that is salicyline and rasagiline, right? So it is thought that rasagiline has neuroprotective phenomena. This prevents the further worsening of these symptoms in the Parkinson's disease patients. If a young patient, like in Wilson disease patient, if he develops the Parkinson disease, so we can use the pramipexole and ropinirole in these patients as they stimulate the D2 receptors, dopaminergic receptors, right? Another drug that is called as rotigotine, so it is present in a transdermal patch, so it has longer action, so we can use this drug as a transdermal patch in the younger patients, right? So we have some other drugs like subcutaneous injection of apomorphine is available, so we can go for that. And also we can give the anticholinergic drug like procyclidine, benhexol, right? So they're gonna improve the tremors and rigidity in these patients, right? So they can precipitate if the patient is having BPH, so they're gonna precipitate the urinary retention in these patients, so we need to take care of that. And surgical treatment is also available, right? That is destructive procedure. We can go for thalidotomy, right? These were done in the past, so palidotomy and thalatomy was done, right? These are no more done these days. So we have a procedure that is called as TENS, right? Transcutaneous electrical neuronal stimulation, right? So this is basically a deep brain stimulation in which we stimulate the globus pallidus internus and subthalamus, right? So the future treatment is reserved for gene therapy, stem cell transplantation. So that's all about treatment part of the Parkinson disease. So let's talk about atypical Parkinson. Right, so atypical Parkinson is also known as Parkinson plus syndrome. So we have the first syndrome that is called as Child-Trager syndrome, right? So this is now called as MSA, multi-system atrophy, right? In these patients, there is this one unique feature that will not be present, like these patients won't be having the resting tremors, right? Other features like bradykinesia and rigidity will be found in these patients, right? So if a patient is having tremors plus if the patient is having rigidity and bradykinesia, along with that patient is having autonomic dysfunctions, like patient is having orthostatic hypotension, right? So we're going to call it as MSAP type Parkinson, multi-system atrophy Parkinson type, right? For orthostatic hypotension, um, if we check the blood pressure in supine position, then we ask the patient to stand up, and after 3 minutes we again check the blood pressure. So if systolic blood pressure falls by more than 20 and diastolic fall by more than 10, so we're going to consider the patient is having orthostatic hypotension. Along with that, constipation and diarrhea, these features can be seen with the multi-system atrophy patients. So MSAP type will be having these features, right? Well, we'll have the MSAC type, that is cerebellar type. These, along with these, the rigidity and bradykinesia, there will be cerebellar signs, right? So they will be having resting tremors, and they will be having intentional tremors as well, right? So they will be having gait ataxia along with that, along with fascinating gait, right? So if we get the MRI brain done, so there will be hot cross bun sign, that is what we see on MRI, right? So treatment, there is no, there's just symptomatic treatment. There is no specific treatment for that because they have poor response to levodopa, right? So that's all about the multi-system atrophy, also known as Child-Trager syndrome, right? Okay, just remember this thing, that they will be resting, they will be having the rigidity and bradykinesia. Along with that, if they have autonomic dysfunction, so we're going to think that the patient might have Child-Trager syndrome or multi-system atrophy. The next thing is progressive supranuclear palsy. So let's talk about this thing. In this progressive supranuclear palsy, the lesion is in superior colliculus, right? So these patients are going to have the Parkinsonism like features, like they will be having tremors. Sorry, they won't be having any tremors, they will be having the rigidity plus bradykinesia, right? Along with that, they will have vertical gaze palsy. So in these patients, mainly downward gaze is affected. We're gonna call it as eyelid apraxia. So they will be having recurrent fall, right? So they will be, because to compensate to look downward, they will be hyperextension of the neck. So if the features having, resting rigidity and bradykinesia, right, and along with that there is Parkinson disease patients usually have the tendency to fall. So if there is hyperextension of neck, right, and along with that there is um, um, rigidity and bradykinesia, and if we do the MRI head, so we can see the hummingbird appearance in these patients. So, and if we get the electrooculography, there will be square wave jerks in these patients. So right, so that's all about the progressive supranuclear palsy. So if we have the Parkinsonism features, along with that patient is having hyperextension of neck, right, to compensate to look downward, as the upward downward gaze is affected. So we will think that the patient might have the PSP. And if we get the MRI brain, so there will be hummingbird appearance, and that is confirmatory for that, for this disease, right? The next thing is olivopontocerebellar syndrome, right? Olivopontocerebellar syndrome. So there will be Parkinsonism and cerebellar features in these patients, right? The next thing is corticobasal degeneration, also known as alien hand syndrome, right? Basically, the corpus callosum that connects the right and left hemispheres to each other, that coordinates by basically right and left hemispheres. So if we see if the patient is having Parkinsonism like features like rigidity and bradykinesia, and there is involuntary movement of one hand, if you try to eat, so other hand stops, try to stop eating, right? So this is called as alien hand. So basically problem is in corpus callosum that coordinates right and left hemisphere, right? So this is where we see tau proteins. Usually see we tau proteins in Alzheimer's disease, right? So we have some other causes of tauopathies, like mnemonic is ACP, so Alzheimer's disease, corticobasal degeneration, and progressive supranuclear palsy. These are the three diseases in which we're going to see the tau proteins, right? So the next thing is Lewy body dementia. So this is also known as frontotemporal dementia, right? So in these patients there will be features of Parkinson's disease. Along with that, they will be having dementia, right? So there are some pediatric onset neurodegenerative disorders like Wilson disease, in which there is increased copper deposition in the lenticular nucleus, right? So this is also known as hepatolenticular degeneration. So if Parkinson's disease is present in the young age group, so we're gonna think that these patients might have the Wilson disease. The next one is called as the Hallervorden spots disease, right? So this is also called as the neuronal degeneration in the brain, right? So there will be iron deposition in the putamen, and this can lead to same features like what we see in the Parkinson disease. So in Wilson disease, if we get the MRI, right, so we'll see the giant face of Panda sign, right? And if we get the Halliburton spots disease, if we get the MRI in this disease, so we'll see the eye of tiger appearance. Usually the eye of tiger shines in the dog, so we will see similar kind of appearance on MRI in these patients. The next thing is Huntington disease, right? So this mostly occurs 40s to 50s, right? So basically this is an autosomal dominant condition, so I have already talked about this thing, right? So basically the lesion is present in caudate nucleus, right? So that's all for today, right? So I just want to mention one thing here, that in Huntington disease, if we get the MRI, there will be boxcar ventricles in these patients, right? And the treatment is the tetrabenazine, right? So in Huntington there will be increased dopamine, right? While in Parkinson disease there is decreased dopamine. So tetrabenazine is gonna decrease the dopamine, right? So that's all for today. So see you in the next video.